Okay, well, welcome. Thank you. It's an exciting moment as we are going to start our PCI program, hopefully after the long weekend, Labor Day weekend. And as part of the preparation, we're trying to get everybody on board in terms of education, understanding what PCI is, the syndromes that we're going to be treating, acute coronary syndromes, because this is going to be very important for this whole region. You could see from this spot here, I could see all the way going southwest and going all the way west. There are no other hospitals, so we're going to be getting a lot of patients from that area. And we're going to have a lecture today and a lecture next week. Today we're going to talk about acute coronary syndromes, pathophysiology, and pharmacology, understanding when the patient lands here, or even from before when the patient calls EMS goes and arrives at the scene, and they start bringing the patient here. They communicate with the emergency department communicates with their staff, with the physician, and a team gets mobilized, especially if it's a STEMI, if the artery is blocked and we have to rush the patient to the cath lab. So, and the reason we're doing this, because I was reading a nice quote this morning in preparation for this as well, is that if we all think alike, then none of us is thinking. So, and the reason is each one of us is going to be thinking of this as part from their own angle, and they're going to alert the others, including the physicians, the ER physicians, the interventionalists, and this happens in the cath lab a lot. Cath lab staff, many times they suggest something to the physician, to the interventionalist, and the interventionalist listens and changes their plans. And it happens frequently when they do that, because they're sometimes focusing on one thing and somebody else is seeing something else. So what is acute coronary syndrome? Acute coronary syndrome is something that has to do with coronary arteries, and basically it's the thing that causes heart attacks. And this happens in phases. So what happens is we have an artery, and that artery is the coronary artery. Coronary arteries provide blood and oxygen to the myocardium. And usually they're patent, and if they're patent, everything is fine. With age, with risk factors that we all know, risk factors are high blood pressure, type 2 diabetes or type 1 diabetes, hyperlipidemia, smoking, sedentary lifestyle, obesity. Cholesterol starts to accumulate in the intimal thickening of the coronary artery, and as it continues to accumulate, those are lipid molecules, LDL. As they continue to accumulate, this can happen here, then this opening starts to narrow. As this opening starts to narrow, it goes from being 100% patent, it starts going down, usually maybe like 10 to 20% plaque, and then 30 to 40%, then 50, up to maybe 69. Until that point, patients are doing fine, although the cholesterol is causing narrowing in the vessel. Only when this becomes 70% or more is that those patients start to develop chest pain with exertion. The reason is that with exertion, heart rate goes up, and blood pressure also supposed to go up. And as those go up, we have to deliver more blood. With a fixed obstruction, we cannot deliver that more blood. The patient starts to feel exertion, chest pain with exertion. They walk, they tell you, I'm feeling tightness in the chest. They cannot pinpoint it. It's something there. This is what we call stable angina. They stop, it goes away. That's not acute. If this thing continues to go on, or if what happens is that this plaque ruptures, once this plaque ruptures, then all this lipid that is here gets exposed to the bloodstream. And when it's exposed to the bloodstream, it's very thrombogenic. And that's what acute coronary syndrome is that there's a clot that starts to form here. And that's when everything starts. So As long as there is no exposure of the lipid core to the bloodstream, it's stable angina. We can treat that. We'll bring the patients in. The patient can be coming from the office with a positive stress test. We take him to the lab, we find the lesion, and we do the PCI. But here today we're going to talk about the acute coronary syndromes, which is that there is a little rupture and there is exposure of the lipid core to the bloodstream. This becomes very thrombogenic, and the first thing it does calls for platelet aggregation and activation. So all those here that's exposed, this is the lipid core, platelets start to come to this site, and as they start to come, they start to aggregate, and they release molecules that cause amplification of this, which is aggregation. They start to aggregate, and then as they continue to aggregate, they call on fibrin as well, and the fibrin starts to cause a mesh around this, and the clot starts to form. So if this is the artery, there's a clot that's starting to form, and there is blood that is not going through here. It's going through, but it is not going through as it's supposed to happen. Patients present with chest pain. They present with electrocardiographic changes. The chest pain comes and goes. Now, if the chest pain comes and goes, we have something called unstable angina, because this clot here is a little small. It washes down. Then again, it happens again. Chest pain happens and it washes down. They're getting unstable angina. What is unstable angina? It's angina that is different than what they were having. Now it's happening at rest. They're in the ER, and they're happening to have chest pain in the ER. And then you treat them, you give them a little oxygen, you give them aspirin, and it washes it away and pain gets better. That's unstable angina. And we get an EKG. The EKG shows signs of that, which is ST depression. That's unstable angina, and then it resolves. That's also unstable angina. If this process, however, continues to a degree that we are no longer able to wash this platelet aggregation with the fibrin on it more than 30 minutes, then what happens is downstream here we're going to start to see microinfarcts, and that's when the troponin comes back positive. You check the troponin, the ER doc has the lab check it, and the troponin comes back positive. At this point, the unstable angina has become non-ST elevation MI, and the reason it's non-ST elevation, this has strictly to do with what is happening on the electrocardiogram and reflecting the fact that, number one, it's unstable angina that has become an NSTEMI, but the only difference between this one and that one is that there is positive troponin. So the troponin is positive. There may be or maybe not EKG changes. So that patient now is at risk of even going further if this continues, also that this could become a fully occlusive clot, and then it becomes a STEMI. It might not happen, but it is also possible that this becomes fully occluded, that no blood is going downstream, and that's when we see ST elevation on the electrocardiogram. And at that point, when we see the ST elevation, is when the clock starts ticking for everybody. We have 90 minutes from when the patient entered the ER. This is what we call the door time. 90 minutes from that time to take in the patient, calling everybody in. It could be 2 o'clock in the morning. Somebody is living 15 minutes away, someone else 20 minutes away. From that moment, we have 90 minutes to bring everybody in, take the patient to the lab, and reestablish flow. And the reason is we have 90 minutes because we know from studies that the earlier the better. The golden hour is 60 minutes, but it's impossible to do in 60 minutes because you need to bring the team in. In stroke, it's 3 hours, but also the golden hour is that 1 hour as well. So we have that 1.5 hours to go ahead and reestablish flow and take the patients to the cath lab. However, if the patient comes in late, they're still having chest pain, and it is more than 90 minutes, we can still take them to the cath lab after a discussion to decide, is this going to be beneficial or not? If it's a real late presentation myocardial infarction and the ECG has infarcted, the troponin is up, the patient's not having pain anymore, we don't take those patients usually to the cath lab if they're hemodynamically stable. So unstable angina can become non-STEMI, that also can become STEMI. However, sometimes the initial presentation is a STEMI. So they come in, this ruptures, and this happens very quickly, very rapidly, that this occludes, and then we see that on the EKG, and we take the patient to the cardiac catheterization lab. Many times when you ask them when you see the patient and you ask them, had you been having chest pain? More likely than not, they'll tell you, yes, over the past few weeks, I've been having chest pain. When I go upstairs, it's something new. I go up to pick up the mail from my mailbox, and as I'm coming back, the driveway, it's a little bit up with incline, and I start getting chest pain. That means this was getting tighter, and then suddenly they got the chest pain. So this is unstable angina, non-STEMI, and STEMI. So the difference here is there is a difference in how we treat those. Unstable angina and non-STEMI is different than STEMI, that STEMI carries with it the urgency of the 90 minutes, which is the door to the balloon time. And the reason is because there is no flow, so everything beyond that point is dying. It's not getting oxygen. And when they say, like, time is muscle, because the more time that happens, that goes on, the more muscle is dead. I call this time is life. The reason is, the more time that lapses, and the patient has a bigger and larger infarct, when we do the LV-gram or the echocardiogram, you'll see that a big part of the muscle now is maybe dead. And that patient now is at risk of heart failure. And heart failure changes all the dynamics of the family, not only the patient. That patient will need to go to a heart failure clinic. Somebody needs to take that patient to the heart failure clinic, especially maybe in the first few months, until all the medications get titrated. And this happens like quickly. It happens like every 2 weeks they have to go get their medications titrated. If that heart failure does not get better, and what we call the ejection fraction over the next 3 months does not get better above ejection fraction of 35%, that patient is going to get an ICD, which is something to shock the patient should they get a ventricular fibrillation, ventricular tachycardia, a lethal ventricular arrhythmia. So the whole dynamics of a family, the children, the grandchildren, we see that all the time. Somebody's bringing the patient because this went on for a long time. Many times the patients, like, they thought it was just like a heartburn and would go away. And they just sat on it. And usually it's women more than men, because they think if they're gonna leave the house is gonna go in shambles. And we try to tell the women, no, if you don't leave the house is going to be in shambles. It's the other way around. I need you to get to the closest ER, to the closest medical facility, so that you get treated and you go back to the house and take care of the house healthy. Not with someone with heart failure and then needing an ICD and so forth. So the difference now between unstable angina, as I said, and non-STEMI and STEMI is what? What is the difference? Is the 100%, okay? It's the total occlusion. So let's talk about unstable angina and non-STEMI. So this is basically the pathophysiology of how things are happening. So the first thing that we give to those patients, so let's say that this is the clot that is happening here. So we have to try to prevent that clot from extending and causing 100%. So what are the things that we do to those patients? What do we give them? First thing, Before the aspirin? Before the nitro? Oxygen, okay? And I want to talk about oxygen. That's the easiest, that's the quickest thing you can give them, is that it's not like a knee-jerk reflex. It's the oxygen, if you give it too much, it can become vasoconstrictive. So we have to be careful. So if the patient's oxygenation is fine, above 94%, we don't need to give that. If it falls below 94%, then you might want to give them a little oxygen. So that's the first thing. The next thing we give them is what? So we talked about oxygen. Aspirin. So we give him 2 baby aspirins, and believe it or not, baby aspirins are as good as streptokinase, which is a thrombolytic, which could bust this whole thing. I remember way back, I had a patient, they called me, the patient was at the mall, she was a lady, and then she came in and she tells me, I started feeling the chest pain, I was shopping, I had aspirin in my bag, and I chewed 2 of them. By the time she was in the lab, the artery was patent. So there was still the clot, but it was no longer. She had the STEMI on the EKG, but the STEMI was gone, and the artery was now, you had full flow. So that's why I ask all my patients, and I keep it in my house, I keep it in my clinic, is baby aspirin chewable, because it helps the buccal absorption. It gets absorbed through the mucous membranes. So we give them 2 baby aspirins and ask them to chew it. And what aspirin is an antiplatelet agent. It's a weak antiplatelet, but sometimes it can help stop this, and at times if it's given early enough, it can help even bust that clot. So that's the next thing. So we give them aspirin. What else do we give them? Nitroglycerin, okay? And that's important. So we give them nitroglycerin. How do we give it? Sublingual. We give them 1 nitroglycerin sublingual if they do not have low blood pressure, and if it's a male who has not used any of the erectile dysfunction medications such as Viagra, Cialis, Levitra, any of those. If they have used those in the past 24 hours, we should not give them nitroglycerin, because that could be catastrophic. It can cause profound low blood pressure, hypotension, and it could be lethal. So that's one question we could ask those men: had you used that in the past 24 hours before giving them the sublingual nitroglycerin? So what does nitroglycerin do? It's a vasodilator. It dilates, basically. Remember, the coronary artery, the one that's affected, is not affected like in isolation of the rest. So this is the one artery here, and there's another artery, and this other artery is patent. So this artery here usually has cholesterol in it. It's a diseased artery. The good thing about nitroglycerin is that it dilates the diseased artery and not the healthy artery. If it dilated the healthy artery, then we would cause a Steele syndrome. Blood will go to where there is less resistance to flow and would affect the diseased segment. It doesn't do that. So it dilates, nitroglycerin dilates this diseased segment and not the healthy one. And it can enable more flow and less chest pain, and treat that with nitroglycerin. Nitroprusside does the opposite. When we have those patients that have severe hypertension, we start them on nitroprusside. Nitroprusside can cause a Steele syndrome in those patients. So we don't use nitroprusside in that. So we give them a sublingual nitroglycerin. How much is a sublingual nitroglycerin? 0.4. How many mics is 0.4 milligrams? 400. You're giving that patient 400 micrograms. I'll tell you why that is important. You're giving them 400 micrograms, like right there under their tongue, and it dissolves within a few minutes, right? How much do you start nitroglycerin drip? When the doctor tells you, let's start nitroglycerin drip, how much do we start usually at? No, the drip. I'm talking IV drip. We start at 5 mics, 10 mics, right? And then we start going up. And the nurses are really, they give the nitroglycerin 400 mics, but then when it comes to the drip, they're really shivering. Oh, can I go up? They're going to become hypotensive. Don't be afraid, because when you give the 400, they usually don't become hypotensive unless there's a reason for them to be hypotensive. They were hypotensive, or there's an RV infarct, or if they have used any of the ED medications. But if they haven't, don't fear going up and titrating nitroglycerin every few minutes by 5 or 10 mics a minute, up to a total of 200 micrograms per minute, okay? So that's the maximum dose. So, because a lot of people think that nitroglycerin is going to cause that patient to become hypotensive. It won't. And you will be able to catch it, and if it happens, you can start titrating down the nitroglycerin. So that is the treatment of the patient. And we give nitroglycerin. Why? It's for chest pain. When it vasodilates, it enables a lot of the blood also to flow through, and the patient does feel relief of chest pain. So, do you know why chest pain happens? Why does the patient have chest pain? The reason that patients have chest pain is as this becomes tight, there's less blood going downstream, and if it's less blood, it is less oxygen. And if it is less oxygen reaching the muscle cells, then the muscle cells switch from aerobic to anaerobic metabolism. And when they switch to anaerobic, that's when the muscles start producing local lactic acid. And lactic acid is painful. And that's why this chest pain is painful. Have you ever exercised and then the next day you woke and all your muscles were aching? That's lactic acid, and it takes a while. You need to drink a lot of fluids, and that's why if you go and have a massage, they have you drink a lot of fluids, because lactic acid can cause all those muscle aches. And the same thing is the heart is a muscle, and it aches. When it aches because of lack of oxygen is because there's a lot of lactic acid. And when this nitroglycerin dilates, it enables us to deliver more oxygen and to help this switch back from anaerobic to aerobic metabolism and decrease the production of the lactic acid. So that's aspirin and nitroglycerin. What else do we give them? Morphine, right? So we give those patients also morphine if nitroglycerin is not enough. If you've given them like 3 sublingual nitros and they're still having chest pain, and you've started the drip and you're titrating up, they're still having chest pain, then we go ahead and give morphine. What does morphine do? It does. So number one, it does relieve pain. It's a pain medication. It's a narcotic. So we give that. It relieves the pain. It enables the patients also that when the myocardium is infarcting, what happens also here is that the first thing that gets affected is the filling of the muscle. It's not the contraction. The contraction is the last thing that gets affected if the muscle is dead. If this muscle is not receiving enough blood supply, then the relaxation starts to get impaired, the diastole phase. And when it starts getting affected, the pressure inside the ventricle starts to go up. We call this the left ventricular end diastolic pressure. And Tal knows that we are all there in the lab and we're trying to measure the left ventricular and diastolic pressure, and in myocardial infarction usually it's elevated. And the reason it's elevated is because this muscle is not relaxing as it's supposed to. And as this happens, then as the pressure increases, this goes all the way back to the lungs, and you start getting pulmonary congestion. And with pulmonary congestion, the patients start feeling short of breath, and you'll see them. And that's when you look at them and they have this impending doom on their faces, and they're breathing a little bit fast, they're tachy breathing, and that's because of this LVEDP. Morphine can help takes this, it's an anxiolytic as well. So it enables, it suppresses the shallow breathing and enables deep breathing, and it takes away the anxiety. And when it takes away the anxiety also, the adrenaline, now with all this anxiety, adrenaline goes up, and we don't want adrenaline to go up in this situation, because as it goes up, it can increase in LVEDP, increase in blood pressure, and we don't want that to happen. Morphine comes and counteracts that by reducing anxiety. It causes less adrenaline, and it does help the whole situation. And in acute coronary syndrome, morphine usually does not cause suppression of breathing. It does not cause that usually in those patients. So we go ahead and we give morphine 2 to 4 milligrams IV every few minutes until the patient has the pain resolves. So what else do we give? So we've given oxygen, aspirin, nitroglycerin, and morphine. What else? So remember, we have here the platelets and we have the fibrin, right? So we need to give something, and thrombin that's here. We need to give something that's antithrombin. And what is that? Before that, so we haven't given that. We're not going to give, hopefully we're not going to give TPA unless there's a big snowstorm and you can't get the team here. That's when we're going to go ahead and give thrombolysis. So we give heparin. So heparin is an anticoagulant, and we give that also to those patients. And what does heparin do? It's an antithrombin, and it comes and it has its effect on those fibrin and thrombin. So it stops the extension of this clot. It doesn't bust the clot itself, it just stops the extension. And it enables our intrinsic TPA. All of us have TPA inside us. When you get stuck by a needle or by a pin, the first thing you see is bleeding. And then the bleeding stops. You just put a little pressure on it and it stops. Sometimes even if you didn't, it just stops because there's a clot inside that has formed. And after the clot has formed inside, TPA from your own system comes and dissolves that clot, and then there's no more bleeding. So heparin stops the extension of this thrombus, and it enables our intrinsic TPA to come and stop it. How much do we give? We give like 4,000 units initial, and then we put them on a protocol. Usually it's a low intensity protocol, and that is under like heparin or under sets. So you go to sets, order sets, and then if you put heparin, gives you low intensity and moderate intensity. So we give them that, and usually it's 70 units per kilogram, and then 70 units per kilogram bolus, and then 16 units per kilogram per hour. And we maintain, how do we follow the heparin? With PTT. So we check PTTs, and the PTT that we want is usually between 50 and 70 seconds to make sure that that the blood is anticoagulated. So we discussed oxygen, aspirin, nitroglycerin, morphine, and heparin. So what else do we give those patients? We're still in the emergency department. We haven't moved out of the emergency department. And we're hoping that the patient is getting better with what we're doing. What else do we give him? Statin we do, but it can wait until after we give it in STEMI, and we give him a high-dose statin because it's been shown that it does reduce mortality, but it can wait until after. We're still in the emergency department, and because you don't want to give something that does not have an immediate effect. You don't want to delay them going to the cath lab if they need to. Remember, we're still talking about unstable angina, non-STEMI, where there is still flow going downstream. Okay? So we've given all those. We can give like a beta blocker. So, and we give a beta blocker. We might need to give a beta blocker if the patient is tachycardic or hypertensive, if the blood pressure is high. It's allowed to, and you could give, if the patient's not bradycardic, if they have not manifested any AV nodal blocking signs like bradycardia, first degree or second degree AV block, then we could go ahead and give them a beta blocker. And usually we do that also after we take them to the lab or after we admit them. Then what do? So now this patient has stabilized. They came in with chest pain. The chest pain is gone. They're relieved. They have ruled in. So what do? Do we take them directly to the cath lab or do we wait? So that question usually is a little bit, there's a lot of studies that have been done. Probably millions, if not billions of dollars. Do it early or not. And early means that you do it within the 24 hours, not like right away. You don't activate the lab unless after we've done all this, the patient continues to have chest pain, EKG changes, they're hemodynamically unstable, they're electrically unstable, they're getting VTAC, then yes, we take them and we're trying to open that artery because yes, the artery might not show a STEMI, it's not 100%, but it can be 99% occluded. And we need to get it and prevent it from becoming 100%, and we need to treat that. But if the patient has stabilized, then we can go ahead and take the patient to the cath lab within the next 24 to 48 hours. It depends. And also there have been studies is when did the patient present? Did they present on like Friday evening after everybody was gone for the weekend, and then they won't get done until Monday morning? So, or did they present on Monday morning? Oh, that's the best time to present to the hospital. Then they take them to the lab, and then they're out of the hospital the next day. Some patients are out from the hospital that same day. You just go ahead and you treat them, put a stent, and send them home. So that is part of the treatment. Sometimes if they're still having chest pain, if they're still having EKG changes, and all this that we've given has not worked, they have ruled in for myocardial infarction by elevated troponin, that's a must, then we can go ahead and use intravenous glycoprotein 2B3A inhibitors, which is a platelet inhibitor. It's intravenous. And I think the one that we have here is aggrastat. We used to have integralin, eptifibatide. Now we have aggrastat. And that is intravenous. It's also antiplatelet. It inhibits the glycoprotein 2B3A molecule, and it prevents the platelets from aggregating. But it comes at a little cost. It can cause more bleeding. But if the patients, as I said, troponin positive, still having chest pain, ECG changes, then you are justified of giving them that medication in preparation of taking them to the cardiac catheterization lab. So we've done all that, the patient has stabilized, and the next day is we're going to take them to the cardiac catheterization lab. So we get them, and the next day they come, or the same day sometimes, and we do the heart catheterization. And in that heart catheterization, this is what we see. This is the artery. Sometimes we see a clot here. There's still flow. Remember, we're talking about unstable angina and non-STEMI. There is still flow going downstream. And once we decide, and usually we can tell from the EKG where that artery is going to be affected, the next thing is, as we do the heart catheterization, you have to know how it's done. And this is done from the axis where we do it, and then the procedure itself, and then axis. Okay, so the axis is usually now we're trying to do more and more radial. A few years back it was femoral. We used to go through the femoral artery, but the femoral artery has less mobility after. They have to stay longer in bed. It can cause more bleeding, more hematomas. And we know now that bleeding in that setting translates, and reduction in hemoglobin translates into higher mortality. So we try to not go femoral unless we have to, unless we couldn't get them we couldn't get access to the radial artery, or sometimes we get access to the radial artery, but the radial artery is a smaller artery and it can spasm, and if it does, you cannot rotate the catheters, so then we go into the femoral. So the axis is either radial or femoral. And we go there, so the first thing is that we give those patients, it's a timeout, we correctly identify who the patient is, we consciously sedate them, and that's an important part, is conscious sedation in the lab, because it prevents, in many times, spasm of the radial artery. Then we go ahead and we give them lidocaine. I think we have 1%, or are we short on that now? We do. We still. I think at Reston we're short. So now we're going to go in. I'm not a good drawer, but this is the hand, and this is the radial artery. Okay. So it gets accessed, and then we put a sheath in, and through that sheath we go ahead and access all the way to the coronary arteries. And so we go ahead and we identify this. The first thing we do is we wire it. We put a very thin wire, 0.014 of an inch. And then we go ahead and preferably I balloon this, and then the next thing happens is this becomes like this, as we ballooned it, and then we go ahead and we put a stent in this area. And we're done. After we've stented this, we take everything out, and then it's access again. We have to pull everything out, and there's a puncture, whether it's here or it's in the groin, we need to close it. And many times we close this. If it's radial, we just pull this out and we put a TR wristband on, and we inflate it up with air until the bleeding stops. We put an extra 2 milliliters of air in, and then there's a protocol. We're going to discuss this post-PCI management, that there's a protocol of how to manage that. We're going to talk about that next time. So here I want to talk about now this aspect of what are we doing here in the stenting part. And that's important to understand. And as I said, we all think together, but we're trying not to think alike. Everybody is talking, and especially the nurses are next to the patient, they're talking to them, and many times the patients remember stuff that they had not told us in the ER, and that can have an effect on what we do. So once this artery now is stented, a stent basically is a metal coil. Now it's a foreign body inside the artery. And if you have a foreign body inside the artery, that can cause inflammation, or in fact it will cause inflammation. So there's going to happen inflammation here. And those struts that are here that are exposed to the bloodstream are also very thrombogenic. You can imagine yourself going inside the artery and there's a stent inside, and there's this glittering thing, which is the stent, like adherent to the vessel wall. The platelets love this. They see that as they go there, and they go hang, and they're kumbaya and holding hands together. If we don't give them antiplatelets, we have to give them 2 antiplatelets. This stent will clot, and believe it or not, it will clot even on the table. I've seen it where it has clotted. You go ahead, you inflate the balloon, you deflate the balloon. If the patient does not have enough anticoagulation, which is heparin on board, and antiplatelet therapy, you just see it in front of your eyes clotting. And then you're in a different ball game. You have to deal with that clot, suction it out. That clot can kill the patient. So that's why it's very important when we give those patients heparin, intravenously, we follow in the lab, we don't follow PTT, we follow something more quicker, which is called activating clotting time. It's ACT. And that ACT has to be anywhere between, depends on what we're using. If we're using a glycoprotein 2B3A inhibitor, which is Aggrastat, then it has to be 200 to 250 seconds. If we're not using that, then it has to be 250 to 300 seconds. Okay? And the reason is because in that range, the clotting is at its minimum. Then you might ask me, why just not give them a lot of heparin and just not follow the ACT? Because once you're out of that range, you become higher than that range, or that range becomes higher, then bleeding can happen. Especially if you're doing femoral, you can guarantee yourself you're going to get a hematoma or retroperitoneal bleed, and we're going to talk about that in complications as well. So that's why those numbers are the numbers where it's least thrombotic and least bleeding. So that's why we have to do that. And usually, so the cardiologist will tell the staff, give him heparin, and then they'll forget about it. And somebody else needs to, we need an ACT. So like in 15 minutes after we give heparin, we're checking ACT just to see what the ACT is doing. The issue is every patient responds differently. Some patients stay with an ACT in that range, like high enough until the end of the procedure. Some patients, you give them, you check it back, and it's 190 now. You have to give it again and then recheck it again. So the way patients metabolize the heparin is different from one patient to the other. So that's why we give those patients heparin, and they have gotten aspirin. And once we decide that we're going to stent, they get a second antiplatelet in the lab. And usually that is either clopidogrel, ticagrelor, or prasugrel, one of those. And that is, we need 2 antiplatelets on board so that those platelets are not going to thrombose, which is called acute stent thrombosis. So this is the first complication that can happen usually in the lab, is stent thrombosis, acute stent thrombosis. And usually acute stent thrombosis is a stent thrombosis that happens in less than 24 hours. It can happen also after you take the patient. It's happened to us. You take the patients off the table, they go upstairs, within less than an hour, they've thrombosed their stent. And then you have to take them back. You can't sit on it. You can't just give them something to bust. You have to go back in and clean that. So that is, and then you give them a second antiplatelet inhibitor or antiplatelet medication. So after we've done that, it's important to understand what type of stent we're going to use. Now, sometimes those patients, that they'll tell you, it's a lady and she was just diagnosed with breast cancer and she needs to have surgery, and she's having an MI. So we have to do that. And if she's gonna have surgery, we're not going to delay her surgery long. So what we have to do then, we have to give him a stent that will only need antiplatelet therapy for a few weeks, up to 4 weeks, so that she can have her surgery. Anybody that needs surgery, like some type of surgery that cannot be delayed, and that's the question I always ask the patients in the ER, do you have any surgery coming up? If they tell me yes, it depends on what type of surgery, then here we don't give them, there are 2 types of stents. There is a bare metal stent, and then there's a drug-eluting stent. We give them a bare metal stent. A bare metal stent is just a metal stent. That's exactly what it is. It does not have any medications on it. So once this stent is in, it causes an inflammatory reaction, and this takes about 2 to 4 weeks, and this intima grows and it covers the stent struts. As it does that, and as it covers the stent struts, the platelets, as they go here, they see no glittering, nothing to play with, and that's why they don't form clots down the road. So acute stent thrombosis is less than 24 hours. subacute stent thrombosis is between 24 hours and 30 days. Okay? After that, so if it is between 30 days and 365 days, that is called late stent thrombosis. If it's more than 365 days, which can happen, it's late or delayed stent thrombosis. So we've dealt with this. Now we have to deal with the subacute stent thrombosis, which is after 24 hours of those patients. So we have to give them the second antiplatelet, the aspirin second antiplatelets, if it's a bare metal stent, until there is intimal thickening enough so that it covers the stent struts and that stent is not going to clot. And then after that we can go ahead and stop one of them, and sometimes even both. They go to surgery and then we put them back on a baby aspirin after they have done their surgery, when the surgeon says it's fine. So why then, the question is, why not just use bare metal stents if then this prevents us from using two agents for a longer period of time? Because what was happening, this happened in we introduced stents, the stents got introduced into practice in the late 1990s. Before that, in 1977, this is the historic aspect of acute coronary syndromes. A guy named Andreas Grundzig from Switzerland used a balloon, a homemade balloon, to open this 90% stenosis. He put the balloon here and inflated the balloon. In 1977, took the balloon out, and the artery became just like this. And this patient still lives until today, and every few years they take that same patient, 1977 patient, and they show him in person in big cardiology meetings and what they did. So that was something amazing at that time. And Andreas Grundzig, he was in Switzerland, and guess who caught on this? The United States. It's like, oh my God, all those big companies, they looked at this and they saw ka-ching dollar signs in it. So they got him here. They said, you need to come here. He said, I will only come here if I get the green card. And they had, he came to Georgia, and they had the green card in their hand when he landed. So, and he was the guy that introduced this, which was PTCA, percutaneous transluminal coronary angioplasty. But this had its shortcomings. Sometimes the vessel will spasm on us. Sometimes it will dissect on us, so they would use prolonged inflation. This continued until the late 90s when they introduced stents. So a stent would be that you balloon this, and then if there's a little dissection here, and we see that in the lab, after you balloon it, there's a little dissection, that's a no-brainer today. Give me the stent, and you expect that to happen, and then you go ahead and you implant the stent, and it looks beautiful before and after if you compare it. So now at that time we were implanting bare metal stents, but the bare metal stents were causing a lot of growth to the degree that it caused something called in-stent restenosis. Have you ever seen a keloid? Keloids, right? So this is like a keloid happening in the arteries in some of the patients. It's like excessive inflammatory reaction to this injury by those steel coils or the metal coils of the stent. So someone in the early 2000s, they started working, said, how can we stop this growth? This is growth, intimal growth. How can we stop it? So they said, maybe we could look at that stent and then put on it a medication. So that medication was it's a chemotherapy. It's exactly like what we give to patients with cancer, but in a very, very, very minute dose. And then we started implanting drug-eluting stents. So drug-eluting stent is a stent that has on its outside little holes, and in those holes there's medication in order to prevent the growth and in-stent restenosis. However, at that time, and this is 2003, I remember I was here in 2003. We were in, I was at Washington Adventist Hospital in Tacoma Park, and the night before, the FDA approved those stents, and everybody was rushing. They were all waiting. I think it was Abbott. They were waiting, and they shipped it. So every lab was waiting. We had a patient waiting because we wanted to be the first that put that drug-eluting stent in the United States. We got it, and I remember the guy, he had, the cardiologist I was with, the vessel was ready, and we were just waiting for FedEx, believe it or not, to show at the door to give us the stent to go ahead and put it. And they showed up on time, you know, like delivery by 10:30. They did show up at 10:30. We got it, and we implanted that stent, and everybody signed that box, the red box of the stents that we have, and we took pictures of it. So, however, we all thought that that was the end of it, no more in-stent restenosis. But what happened is, because this is chemotherapy, so this, you still need a little bit of growth to hide those shiny, glittery stent struts from the platelets. And when you use this, this is chemotherapy. This is like a nuclear bomb being dropped here, or chemical weapon being dropped here. So nothing is going to grow. So it is going to take a long time. So we were stopping the medications after 4 weeks, but there was still glittery, shiny stuff, and the patient started coming back with subacute stent thrombosis. Okay? Because it's not just a bare metal stent, it has a medication, and that medication is preventing the growth of the intima and causing that necessary inflammatory reaction, so to hide the stent struts. And that's when we started seeing, okay, we need to extend it, and we extended this up to 1 year. At 1 year, then you're nearly guaranteed that there's going to be no more, and I say nearly because no one can guarantee for 100%. There have been cases where down the stream we had to stop it, like years later, and still the patient presented with stent thrombosis, delayed or late stent thrombosis. So this is why we use that, and that's why it's important to understand, because if we put that in, then the patient has to take 2 antiplatelets for at least a year. Now with the new stents, they've come up with new stents that have thinner struts, so they're really like, they can be covered more easily. We go up to like 6 months of coverage. And that's important, and that becomes a dilemma. So what do you do with patients that they need a drug-eluting stent, but they're going to have surgery? I remember, like, I had a patient who was a young patient, was to undergo bariatric surgery. He had diabetes, hyperlipidemia, high cholesterol. I cath him, he's got a proximal LAD lesion. And a proximal LAD lesion, you really don't want in-stent restenosis happening in that. So I put a drug-eluting stent. And he got upset at me and said, I need the surgery done. I said, but you have a proximal LAD, and I put you at risk should it like become stenotic again. So can't we delay that? So then he had to bargain, we had to negotiate, me and him, and then finally we were able to stop the medications at 6 months, because we used the second generation, and at 6 months we stopped the platelet. He underwent the surgery and lost quite a lot of weight. So, and he was really apprehensive. It was affecting him. It was causing him a lot of money because of all the diabetic medications, all the antihypertensives, and once he lost the weight, he came off of a lot of those medications. So this is what we do in the lab. Those are usually like complications that happen within the lab, and I'm just telling you this because you're going to hear about it when you get signed out, like from the nurse that is signing that out. Oh, this patient, for example, had acute stent thrombosis. We fixed it, and now everything is fine. And usually they come with, if there is we thought there is a remnants of clot. Sometimes if there's a clot, it can go downstream and it can still be there, so that's why they come up with a glycoprotein 2B3A inhibitor, Aggrastat, that's going to infuse maybe up to 12 or 18 hours, then it's off. So do you have any questions? This is just pathophysiology and just understanding what's going on and understanding the pharmacology and what we're going to do. Next week, we're going to go through the complications that happen after all this. So we're done from the cath lab part, and now the patient's in your hands, and you need to figure out what is happening to that patient and how you can start. If there's a complication happening, you can start working on it even before like calling the physician or calling somebody. All right. Any questions? All right. Very good.